Imagine this, a perfectly healthy kid suddenly covered in bruises that came out of nowhere. It's a really scary situation for any parent, and it often leads to a diagnosis of pediatric ITP. So in this explainer, we're going to walk through this condition step by step. We're going to follow the entire clinical journey, from that initial shock of diagnosis all the way to the calm of long-term management. Let's dive in. So, our journey through this ITP pathway has 5 main stops. First, we'll get a handle on what exactly we're dealing with. Then, we're going to put on our detective hats and learn how to diagnose it by figuring out what it isn't. After that, we'll hit the big one, the core treatment decision. From there, we'll look at the tools we have for acute intervention, and finally, we'll talk about the road to recovery and what happens if this thing decides to stick around. Okay, first things first. Before we can even begin to talk about treatments or outcomes, we really need to understand what pediatric ITP actually is. At its heart, ITP is basically an autoimmune mix-up where the body's own defense system starts attacking and destroying its platelets. Now, the official number for a diagnosis is a platelet count below 100. But here's the thing you have to understand. Most kids who show up with ITP have counts that have absolutely plummeted, often way down below 20. And that huge gap between the official definition and the scary reality is why this causes so much alarm at first. Now, despite those incredibly low platelet counts, the outlook is, believe it or not, overwhelmingly positive. This is probably the single most important message for families to hear. The vast majority, we're talking 75 to 80% of children, will have a full recovery within 6 months, and that's often with little to no treatment at all. The disease's timeline is broken down into 3 different phases, and it's all based on how long it lasts. The first 3 months, that's what we call acute ITP. If it hangs around from 3 to 12 months, we label it persistent. And only after it's been a full year does it get the label of chronic ITP. And this timeline is absolutely critical for how we approach managing the condition. So, how is ITP actually diagnosed? Well, it's really a process of elimination. Making a confident diagnosis is just as much about proving what it isn't as it is about proving what it is. A classic case looks something like this. You have a child who was totally healthy, and then, all of a sudden, they develop widespread bruising. Those tiny little red dots we call petechia, and the bigger purple spots known as purpura. And very often, this pops up a few weeks after a pretty standard viral infection. What's not there is just as important as what is there. We have to hunt for red flags, things like an enlarged liver or spleen, that's hepatosplenomegaly, or swollen lymph nodes. They all point away from ITP. And here's something that might seem a little backwards. Major bleeding, like from the nose or gums right at the beginning, is actually a red flag itself. It tells us we need to be looking for something else. So that brings us to the investigation filter. For basically every kid with suspected ITP, the baseline workup is simple: a full blood count, a look at the blood under a microscope, and some basic screens. The more invasive stuff, like a bone marrow aspiration, that is not routine. It's saved for very specific, atypical cases where those red flags we just talked about are present. Okay, so we've made the diagnosis. Now we come to what is, without a doubt, the most critical decision point in the entire ITP pathway. Do we actually need to treat this? And this brings us to the absolute golden rule of ITP management. It's so important, I'm going to say it again. Treatment is dictated by the severity of the bleeding, not by the platelet count. What does that mean? It means a child with a really low count of, say, 8, but no active bleeding might just be watched carefully. Meanwhile, another kid with a higher count of 30 who is bleeding needs treatment right away. This one core principle, it logically splits how we manage things into 3 totally distinct paths. You've got the no treatment R, which is for the vast majority of kids who aren't bleeding much. Then there's the moderate bleeding path for those with nosebleeds or gum bleeds that won't stop. And finally, the significant bleeding pathway, which is an urgent protocol for those rare, severe cases. All right, so for that smaller group of kids who do need some kind of intervention, what does that acute treatment actually look like? Let's take a closer look. From moderate bleeding, think of a nosebleed that just goes on and on, we have 2 main options. We can go with oral steroids using either a 14-day course that tapers down or a shorter, high-dose 4-day course. The other option is the IV route, a single dose of intravenous immunoglobulin, which you'll hear called IVIG. Now, for significant, life-threatening bleeding, this is an emergency. The protocol is immediate action. We're talking platelet and blood transfusions, along with really powerful IV treatments like high-dose methylprednisolone or IVIG. This is a situation where you absolutely must call a pediatric hematologist, no question.
So, if we look at our options side by side, you can see a pretty clear hierarchy. IV methylprednisolone, that's the heavy hitter, saved for the absolute worst bleeds. IVIG is more versatile. You can use it in both moderate and severe cases. And oral prednisolone is really the go-to for that moderate, prolonged mucosal bleeding. Each one has its own specific dose and duration, which gives doctors a whole toolkit to choose from.
Okay, let's fast forward. The acute crisis is over. What does a safe discharge look like? And how do we handle that small percentage of kids whose ITP doesn't clear up quickly? The cycle for a safe discharge is pretty straightforward. The patient needs to be totally asymptomatic, and we need to confirm their platelet count is back up over 100. Then, they go into an outpatient monitoring schedule with blood tests every couple of weeks until everything is stable. And crucially, we have to counsel the parents that there is about a 20% chance of a relapse. Now, if the ITP lasts for more than 12 months, our entire philosophy, our whole way of thinking has to shift. In that acute phase, we're assuming it's a one-off, post-viral thing. But in the chronic phase, we have to start actively hunting for an underlying autoimmune disease or an immunodeficiency. And the bar for starting treatment, it gets set much, much higher. And this shift in philosophy has very real, practical consequences. For chronic cases, the investigation goes way deeper. Before any long-term therapy is even on the table, a bone marrow aspirate becomes mandatory to make sure we're not missing something else. And the treatment itself becomes very selective. It's reserved only for kids with extremely low counts who also have a history of bleeding again and again.
So this algorithm here, it really pulls our entire conversation together into one single logical pathway. It's a clinical roadmap. It starts with that initial suspicion, moves you through the red flag check, and then it branches out based on bleeding, all the way from just watching and waiting to the most urgent interventions. And it even maps out that transition to chronic care. It's the whole journey, right there on one page.
But a pathway is more than just a flowchart. Managing ITP well involves a huge amount of parental guidance. We're talking strict advice on avoiding NSAID medications like ibuprofen, having careful conversations about contact sports, discussing any planned procedures with a hematologist first, and connecting families with support networks. And that leads us to what might just be the most human and most vital part of this whole protocol. Reassurance is a primary clinical intervention. For a terrified parent who sees their child covered in bruises, managing that anxiety and giving them clear, calm information is every bit as important as any drug we can prescribe. And this really brings us to our final critical question. We have these elegant, evidence-based pathways, which is great, but the challenge that remains is this. How can we do a better job of integrating real, family-centered psychological support into these rigid protocols? How do we make sure we're always treating the anxious family and not just the low platelet count?